Hi, everybody, and welcome to the EMS Today Show. I'm AJ Heightman, Editor-Emeritus, and we have an interesting show today. With me is Douglas Butler from ImageTrend. Hi, Doug. How are you?
Good, AJ. How are you?
I'm doing very well. I had the opportunity to review the ImageTrend Collaborate report, and it's an amazing piece of work. I reached out to you and to my good friend Janet Leon and said, hey, I'd like to have you on the show. To talk about what some people might think is really boring data statistics, right? But you guys have always, ImageTrend has always impressed me with the way that you're able to do it. And this report in particular was pretty important. So let me share my screen and I can show you guys exactly what I'm talking about. I have been with JEMS and the Editor-Emeritus for a collective 26 years. So I've seen my fair share, a number of reports. And Doug is Director of Clinical Services in ImageTrend's Clinical and Research Services Division. And get my slides clicking here. I feel that my job as an educator and as the Editor-Emeritus of JEMS is to make you think of important subjects, data and trends, very important today, that you might not be thinking of, but they're important to you, your agency, your patient, your safety, or your career. We've been living in a very strange world, as Doug will attest to, in looking at the data and some of our ups and downs. And their data in this report is an amazing 3-year collection of data that will really show you some of those trends to make you understand where we've been and where we're going. You can download the report, and it's going to be up here several times, but just write down www.imagetrend.com/collaborate report, COLLABORATE report. Doug, you joined ImageTrend in 2018. You're currently Director of Clinical Services, but prior to that, you had a long-standing career. You've really kind of done it all. Some of the things that I've done as well. You've been an EMT, a medic, a field training officer, 911 dispatcher, an EMS educator, regional faculty, clinical manager. You've dealt with grants and data and statistics, but you really have discovered your passion. Tell me what you really love about your position at ImageTrend.
AJ, I love the ability to look at data and to see where EMS has been and where we're going, and seeing that what we can do to keep that an enhancement of EMS and keep us moving forward by making clinical and patient-driven decisions.
Well, I think as we go through this, I just want to show you kind of their color code. Again, the report is referenced down below, but we're going to talk about the intro, the collaborate, and then talk about the overview, a little bit about COVID, influenza, traffic-related data, behavioral health, alcohol, suspected drug use. And within that, we're going to talk a little bit about Narcan, fentanyl, all those little controversial things, maybe show you some things that are important to your agency. I'm going to guarantee you we're going to show you things that are important to your agency. And then we're going to kind of sum it up in the end. But I'm going to focus on these main topics in here. COVID, influenza, traffic related, all the ones that I just referenced. And at the end, if you download this, there's a tremendous reference guide for those that you want to be able to source your data. I'm going to guarantee you that managers that are watching this podcast will be able to download this report, use the stuff that I've gleaned for you from my total career, and gave you things that I would walk into a city council chamber with, really able to use my data when somebody challenges the number of 911 calls I have or transports or those kind of things, and be able to use some of this data as solid evidence. The Collaborate is really a research and analysis program that's dedicated to providing vital insights into clinical, operational, licensing, credentialing, system of care registries, public health data for the enhancement of EMS and healthcare industry. What's important is that you guys have identified the data. And what's really important is that ImageTrend is not a company that just likes to work for its thousands of customers, but those customers are so satisfied that they would allow you to use their data. Am I correct?
Yeah, AJ, our clients have opted into this program. And like you said, we de-identify it, meeting federal and state laws, and really kind of trying to be good stewards of that data and use it for research.
And I've been to your conference. I've enjoyed your conference every year. We're a little disrupted by COVID right now. Good friends with Mike Brady, your founder and CEO, and or Mike McBrady, I'm sorry, and certainly Janet over the years, and Joe Graw. So you have all of the enthusiasm of a family. When I'm there, I find people that have peer support, and I think that's really important for a business and for anybody who uses you. So kudos for that. But you also have Morgan Anderson, who's an epidemiologist, and that's very rare for a data company to have. So we're going to see some of the work that I'm sure that she's had her mind involved with, and we're going to talk about how you can see spread of public health issues and epidemics. You can see trends from the data, call volume, dispatch reasons, personal protective usage, established benchmarks, et cetera. And there's a lot of little caveats in here that we're going to point out. Many of you weren't even recording that you were using PPE, and then all of a sudden it comes, well, who needs PPE? And you can't justify your request for that. And we're going to show you how the data is going to help you with that. And so this is going to show you insights to not only local, state, and federal, but the whole healthcare industry as a whole. And ImageTrend has customers across the entire United States. Am I correct?
That's correct, AJ.
And this data comes from across the United States, thousands of providers. And since it's the first report, the collaborative expects to build off these findings, as well as add additional topics. And Doug, you and I have talked offline about things like vaping and other things that you've already incorporated in, and we'll explain to the viewers why that's really important. But this is AJ's most important takeaway. This data report has credibility. And I remember when I was going to Lehigh for my master's and they put me in a statistics class, I had migraines every time I walked out of that class. And the instructor would say, oh, you don't have a big enough N value. What do you mean N value? Well, the higher your N value, the bigger your credibility. You got to give me a report, like you'll hear some reports now of 100 or 1,000 patients or 10,000 patients who they've tested for COVID by comorbidities, et cetera, and those reports have credibility. Well, guess what? This report uses data from across the nation for more than 17 million EMS incidents. Just try and wrap your head around that. Doug, that's a big number, right?
It's a huge number, AJ. I think it's one of the largest compiling of EMS data that's used for research out there. And it's just when we started this project, I would never have estimated we would be at $17 million or 17 million records for our first report. So
well, and back in the days when we used to do the survey of the 50 largest EMS cities, people would salivate waiting for that to come out. When's it coming out? And that was only 50 of the largest EMS systems. You're talking about thousands here and records, so that the validity, and you used 3 years, you probably could have used 5 years, but you used the last solid 3 years, and that's what's important for us to keep in mind. So as we move, everything that we're saying, you have to understand, comes from an N value of 17 million, and that has really high statistical significance from 3 complete years. So let's get into it. The overall EMS incident volume increased by 12% from 2018 to 2019. Doug, that's important. You've been involved in the service. You need to be able to prove to the people that are providing funding to you that you need more crews, that you have more time on the street. And everybody can compare their own data to this. Am I correct?
That's correct. And the reason why we built these metrics and these kind of itemized specific statistics is so that you could run your data and compare to what's in this report very easily.
Yeah, and I think that's interesting. So you go back and you look and see when you download the report, well, what was our increase in call volume? Because everybody's talking to me about, oh my God, the latest is we have a significant dip in call volume because people weren't calling us during COVID. And yet the people that fund you, maybe some municipalities are going to say, well, less calls, less money. No, guess what? When the doors open up from the pandemic, you're going to see the call volume skyrocket. And I don't want, please remind me, because I don't want to forget, Doug, to talk about what's going to happen with the long haulers, because this thing is not going to be over for a long time. From January of 20 to April of 20, there was a 22% decrease in incident volume. And you could look at your own records and see if that's consistent with what you saw. And there was a 14% decrease in the month of April of 2020 compared to April of 2019. So Doug and I, we've talked about that. And as soon as people started to hear that there was infections going into the ER, ER visits dropped off as well, right?
That's correct. Yep. We were, AJ, we were actually thinking as we reached out to clients throughout 2020, some saw, anywhere between 10 to 40% decrease. It was quite interesting to look at that global data and look at the average number is 0.2%. That's a significant decrease. And
there's probably 1, 2, 3 dozen things that we could look at. Transports fell off. Some crews had to lay off transport crews. Emergency call volume dropped down, but in most cases, you still had to cover your area. There was a slight increase in call volume in the summer of June, July of 2020 compared with the previous summer. We think likely due to lifts in stay-at-home orders due to COVID-19 and the pandemic, right?
Yeah, so we did correlate some of the rate or the call volume increases to when states lifted their stay-at-home orders. And you can kind of see the call volume increase and decrease by the kind of the waves of the pandemic too in 2020.
And I've been at your shop, and I know you kind of have a war room where you kind of look and see, well, oh, this is happening in the news, what's happening in EMS. And so looking at things like the last quarter of 2020, saw some of the highest rates of COVID thus far in the pandemic, also saw a 10% decrease in call volume compared to 2019. And a lot of that has already been reported in the news. People didn't want to go to the ER. They were afraid that they were going to the source of the infection. They were afraid of this whole thing. They didn't quite understand it. Even our EMS crews didn't quite understand it. And this will put it in perspective. Decrease was also seen in April of 2020 compared to the previous year, 16% for 911 incidents where patient contact was made. So those studies are familiar to learners study and may be related to changes in lifestyle, right? Less driving, recreational activities, and social perceptions, fear of infection. So we've talked, and I was talking to somebody else about the data, and they said, well, a lot of people said they were afraid to call us for 911. They walked away from incidents. They didn't want to get involved because they knew they'd, were sending somebody into a place that maybe they shouldn't go. And then it was a public education campaign that ERs were saying, no, we have good PPE, don't stay at home. This is a very deadly disease incident. And so incidents began to kind of level off. I personally watched it on some of the Eagles meetings with FD&Y's call volume. It went crazy. Their call volume dropped, then it increased, and then their cardiac arrest significantly increased as people started to basically die at home.
And
70%
AJ,
of EMS incidents were 911 responses with patient contact. You want to say something, Doug? Go ahead.
Yeah, one thing about the call volume, what we did actually find is that when we looked at patient population, so we looked at the strokes and the heart attack patients or STEMIs, the patient population percentage stayed the same. So we weren't seeing more strokes, we weren't seeing more STEMI patients. But what we did see was the onset to activation of 911 was an hour longer than previous years. So that kind of doubt of should I go to the hospital, should I go to the ER was very relevant. And you could tell by that delay in activating 911. And we don't know if that delay was because they were debating or maybe because they were at home and no one was watching them. But we did see a significant increase in the time from the symptoms to the time they activated 911.
So I'm going to ask you to remember that 71%, because when we come back next year, I'm going to tell you that I think that that's probably going to increase significantly. I think EMS responses are going to increase. And I know, and I've talked to Doug, they've already studying things that relate to COVID. If you're not familiar with what a long hauler is, it's a long hauler is somebody who may be a young, rather healthy 24-year-old EMT who says, I'm not going to get I'm not going to go for the vaccines. I'm not afraid of COVID. My friends have had COVID. I'm going to be fine. What I want to impress on you as an older person in EMS is that I see COVID like a little Pac-Man. You might get some of the Pac-Men, but there's still others that are roaming around and can get activated. Now, they can get activated and they can cause a stroke, or they can cause a heart attack, or they can cause a PE. So we're already finding EMS systems reporting that somebody who was rather healthy and thought that they were over the curve, all of a sudden now can't move, they're lethargic, they have memory loss. This is a very, very nasty problem. And I beg you, and I'll beg you again, get the vaccine. Then you only have a 5% chance of getting it, and really a 0% chance of dying. But if you get it and you think you beat it like the common cold, this is not the common cold. We'll talk about that again. Approximately 30% of EMS incidents from 2018 to 20 came from the age group 65 to 84, with an under 10% coming from the 85 years old or older. Now, that may not be a statistic that is going to knock you off your chair, but it validates that our country is aging, right, Doug? And it's only going to get older.
Yeah, we're watching those age ranges shift over year. So this population is increasing.
So you can basically say to a city council, 40% of our incidents from 2018 to 2020, or 40% of the incidents pretty much on a nationwide look are over the age of 65. So we do need to have, injury prevention things, and we do need to have community paramedics, and we do need to have those kind of things. The largest change among age groups utilizing EMS services were in the pediatric age groups. This saw a 19% decrease from 2019 to 2020. You want to talk about that, Doug?
Yeah, we found it quite interesting, and I wasn't suspecting that big of a drop, knowing that schools were not open and recreational sports were canceled. We were suspecting around 8 to 10%. And when we looked historically, a lot of these locations where pediatric patients are being picked up are from schools, are recreational areas, and it makes sense. It kind of corresponds, but as we'll kind of just talk later, it's interesting to look at those changes in why they called 911 for these pediatric populations.
Yeah, and we will talk about that. But mothers were not taking their kids to the ER; they were afraid. They weren't listening to what Fauci and other people were saying about how the very young were not as susceptible to the disease, and so even the kids going outside and playing. The social network was gone, so the number of EMS calls began to dip, particularly from pediatrics. Overall population composition is expected to shift to an increase in the older age categories and decrease in pediatric ages by 2060, and there's great footnotes that you can follow on that. That's because access and advancements in healthcare for the elderly, along with lower birth rates, are thought to be the explanation for that shift. This population shift may be an indicator in continued increase in EMS call volume due to the largest population using EMS services being within the older age group. That this for me as an operations director would be more justification. When I was in at Citronia in the Allentown, PA region, I kept talking about transport vehicles and transport vans, and it was not that hot a commodity. And I think when I left Citronia in '95, they had 3 vans, and now they probably have 15 vans. That's an indication. That's just one look at one service, but you see a lot more of let's move the elderly around. And even with funding now, particularly with the new rescue bill, there's going to be funding for treat and release. And I think that's really significant. In AMT, it's the first time that I really saw NAMT, IFF, IFC, NAMSP all get together and say, look, we need this adjustment. We are not just a transport service. And I think when all bad things happen, something good happens. And I think that's a good thing that happened. The majority of EMS requests for services are 911 responses, 84%, followed by interfacility transports. That's a pretty solid number. And that's coming from some agencies that don't do any transport at all to agencies that do a tremendous amount. But the most notable change in requests was a 24% increase in the proportion of interfacility requests in 2020 compared to 2018, and an even higher request proportion for the first half of 2020. You want to talk about that, Doug? Does that stand out to you as a?
Yeah, think about interfacilities. You're moving patients. You're trying to get them to the right level of care. And I think early in the pandemic, with the ventilators and trying to get the right people to the right equipment, we weren't shocked that there was going to be an increase. But I think the increase of 33% is significant. I think not a lot of people are used to it. And we, like you said, we do have agencies that participate and collaborate, and all they do is interfacilities, and we have those that do 911. But I think everyone was kind of repurposing and thinking of the new EMS kind of structure during the COVID pandemic is it's not about bringing people to the hospital. It's going to be moving these people from hospital to hospital or skilled nursing facility and getting them to the right definitive care.
And if you've ever followed what happens in hospitals, I mean, you got to really, I'm not just saying follow the money, but you really have to follow the care. In San Diego County, for example, our ICU beds became so premium that they basically changed their policy that they would not accept ambulances from outside the region, which would be their main region in the San Diego City area. And so those patients had to go somewhere else, and they had to be transported somewhere else. And patients that were there were being transported out of many facilities around the country to facilities that weren't overburdened. So the shift really was happening, and EMS services may not have realized that. So we're talking about 14.1 million EMS response requests here, followed by interfacility transports. Let me see. Well, they're essential. The evaluation of service requests, including interfacility transports, is really important for you to understand with respect to your resources going forward and seek ways to improve operational efficiencies. Many services that I'm familiar with are finding ways to streamline sending specialized crews out, not necessarily always sending an ambulance, and cutting down on that. There's a new service that's available through a national network now, where they'll come in and they'll set up treat and release protocols for you and have physicians that will take the responsibility for that. If you're in a rural area and you don't have that capability, pretty soon this national network is going to be available. All you're going to have to do is contact them. They'll be able to see and talk to your patient, and off we go. This is table 1 from the report, and I give you the source down below again, where you can see the shift in the data. And I'll let you make some of your own comparisons, but this is a really good, if you look over at the far right in the blue average, that's really important for you to take a look at to see where these calls were: medical transport, public assistance calls. Look at, they were 0.4%, 0.4%, 0.34%. They didn't really change. The public wasn't calling us for additional assistance because actually, many people said that when they were driving down the street with their lights and sirens on, the public actually got nervous because they saw the ambulance as a source or a breeding ground for infection, which we know is not if we're taking care of our vehicles, and thank God that we are. Patient dispositions, treat and transport, 60%. Call cancellations, 12%. Now, that's a valuable number because when I go before a city council or somebody to justify my budget, and they say, well, and I say, well, 12% of the time, we're sending a crew out that can't be available to go and get a reimbursable call. And that's downtime. That 12% of the time is lost revenue for us. And so we can't take a budget cut. That's a pretty solid number. Well, where did you get that? We got that from millions and millions of calls off of thousands of services. Patient treat and transport refusals, AMAs, 10%. You're going to see as you look at your own data, though, that a lot of the treat and refusals began to happen with COVID. Many practices have been impacted, such as incidents resulting in transport to definitive care, and as we'll talk about, right, Doug, the field death pronouncements. That's something new for many services. While they made up only 1% of all patient dispositions, there was a 27% increase from 19 to 20, in 2019 to 20, and a 67% increase when comparing April 19 to April of 20. The largest increase occurred in the older age group, not surprisingly, with a 44% increase in 2020 compared to 2019. And overall field pronouncements in the 65 plus age group accounted for 48% of all age groups. That's a really high number. And it's also a psychologically high number because there are many people that we left at home that we used to code. And I've talked to many people who are having a hard time dealing with this. I'm hoping that as we come out of COVID, that we'll be able to go back to our good resuscitation practices. Because, right, Doug, many services after 20 minutes called the code. Am I correct?
Yep, and a lot of states implemented policies in counties that would 20 minutes work up, or on witness arrest with no no shock rhythm. A lot of changes were made in 2020.
Yeah, and I think a lot of changes were made if you thought that there was an indication the person had COVID, and if there was a history of it within the family, or if there was a history of why they didn't call 911, and you get in there and you have an asystolic patient, you had a lot better justification for calling that particular code. Now, going forward, I'm going to tell you that if there's no indication for COVID, I'd be telling my crews, once we come out of this curve, there is no science that says we can't resuscitate somebody after 20 minutes. In fact, just the opposite is the case. I could show you cases where people have been resuscitated after an hour, 2 hours. They've been on mechanical CPR devices and on ECMO for days. And many of these patients that you see that went to the hospital in COVID were on I just saw a police officer on 60 Minutes, I guess it was, for 5 months. He was on ECMO. Can you imagine what that bill would be? So just a little tip there. So the adoption of non-transporting patients without return of ROSC in the pre-hospital setting has been a standard across the country in many of the high performance systems, but maybe not in your rural system, or maybe not in your regional system. And now you've adopted it. And if you haven't, there's plenty of places that you can get those procedures. You can get NAMSP's position statement on it. There's a lot of things out there for you to see. It could also be from patients waiting to call for us. And we know that to be the case for fear of infection or less social interaction, where bystanders are calling during medical emergencies. I don't know it for a fact, but there's people that are studying what the number of citizen access results are. And, surprisingly in Seattle, where they've done a great job of educating their people, and in Anchorage, Alaska, where they've done a great job as well, I'm just picking on two, their citizen involvement has stayed the same. And that's because they've taught people that it's hands only, and it's hands on the chest. You don't have to go near an infectious airway. Historical patients refusing care and or transport accounted for about 5 to 20% of patient contacts, depending on the type of incident. So there was an increase there, right, Doug? And through May of 2020, it went up about 21%, but then it went back to similar levels seen in previous year for the remaining of 20. So our data has kind of fluctuated. Isn't that surprising?
Yeah, we saw that spike right after that first kind of wave, that stay home order. And then after things kind of, that first release of people kind of started the order started being released, you saw the AMA kind of go back down, and it's kind of standard and plateaued. But I think that initial fear of, like you said, I don't want to go to the hospital, I don't want to be exposed. I think the hospitals did a lot of great messaging that says, hey, we're safe, we're ready, we're wearing PPE, we can handle your situations. Don't stall, come.
Let me see where I'm at here. Oh, we're going to start talking about some of the topics. We're going to really dig into them now. And obviously, we faced a lot of new challenges every day with exposures on every incident, but the risk of, I know many crews that were, gowned up on every single call, which I don't blame them. But then we saw a shortage in PPE. So people got a little bit more consistent with their procedures. So there were a lot of safety protocols, policies to ensure not just the safety of the patient, but also the cares and their providers. I just did a podcast 2 days ago on Safety Neb. It's a brand new face mask that does not allow any aerosolized medicines and exhaled air to come out through the special filters that are in that mask. Now what that does is it opens up the whole world again to give an asthma patients the care that we should be giving them. And so, hats off to the doctor, Dr. Lewis from Northern California. He, in less than a year, brought this product to market. And for $10, it's well worth it. Anybody who has an asthma patient, for sure. Additionally, determined and identification of suspected COVID positive patients in the pre-hospital setting. certainly had its challenges, but we're going to highlight several aspects and the data in here. As Doug and I talked to you about, obviously the documentation of personal protective equipment, I'm going to say basically stunk before the pandemic. And if anything's alerted us for it, I mean, if you go to a county government or emergency management officer and tell them, well, we need X thousands of gowns. Well, how many have you used in the last 2 years? You can't tell them that. But this data now from ImageTrend and others will be able to help you with that. Less than 5% of EPCRs had documented PPE usage in the NEMSIS-defined fields prior to March 2020. You weren't surprised by that, Doug, as somebody who's been in the field, right?
No, I wasn't at all. Those are optional fields, and I wasn't surprised. But the next stat kind of blew my mind about the increase.
Yeah, well, it was an 800% increase in the documentation of PPE occurred during a 3-week period starting in March. And what's significant for those of you who are field providers at any level is that sometimes you think filling out a box or tapping on a screen is extra work. This is very valuable information. It's very valuable data, and it's really important for your safety. At some point, if you become sick and you show that you were well dressed in PPE, it's your documentation as a service that person had proper PPE. It remained consistent for the rest of 2020 with 48% of incidents documenting PPE. That's good. It's not great, but it's a heck of a lot better than 5%. I'll give you that. That's a big return on your investment. Now, many of these things are controlled by local and state agencies. So as concerns for shortages grew, the underutilization poorly demonstrated the actual amount of PPE. So again, am I lecturing to you? Yeah, I am. You really got to do this because as a manager, I would want to be able to show that I need the PPE and show just how much. I wish at some point we could have a report that shows how many masks are deployed just on a given shift by a given person. Here's my biggie, boy. A couple of years ago, I came out and I really took a beating as the editor of JEMS for saying that EMS personnel were not taking temperatures. And I got all kinds of excuses back to me. Oh, it's not a vital sign. Well, you check any textbook, and I'm going to tell you something. Taking a patient's temperature, not just the back of your hand on their forehead, is a vital sign. There's a reason they do it in every emergency department. Then I got from physicians, there's not an accurate thermometer. And I'd come back and I'd say, really? What are you using in your emergency department? Well, they'd give me a name. I'd say, so you're saying that's not accurate? Well, that's what we found works for us. I said, well, then it should work for EMS crews. And then all of a sudden people said, well, you can't use this type, you can't use that type. And all along comes the pandemic. And even though it's been taught as a vital sign, it hasn't been a common practice, with less than 15% of 911 incidents documenting temperature prior to 2020. Now we're talking about 73 million. Am I talking about, Doug?
Yeah, so this is out of 14 million records.
Out of 14 million records.
Only 50% of them had a temperature document.
Right. And we know today that almost any patient that we see could be suspected of COVID. And I can't even go into some stores in my community without them pinging me. I certainly can't go for blood work or anything else until I answer those magical 4 questions and get my temperature taken. So we started to see it increase by the end of 2020. Acquiring temperatures in the pre-hospital setting doubled up to 32%. I'll tell you, I'm not happy with that. If I was still an ops director, I'd still be professing that I want a temperature on every call. It doesn't take that much, really. I mean, you have it in your jump kit, you have it in your ambulance, whatever. And you can't tell me that they're expensive. They're really not that expensive. EMS care providers select impressions, and talk a little bit about impressions, Doug, so people understand what this means when we go through the next couple categories.
Yeah, so paramedics or EMTs get 2 impressions. They're primary impressions, secondary impressions. Impressions are supposed to be the most acute condition from point of contact to transfer of care. So, I always give the example, if you pick up a patient with chest pain and you do a 12 lead and they become a STEMI, STEMI would be the primary impression, chest pain would be the secondary. So the primary should always be the most acute condition. What's going on?
And ICD-10 codes are things that many may not be familiar with. Certainly your billing department's familiar with them, but the reality is that there are codes for every impression that we might have. And a company like ImageTrend makes sure that those are available on your record. And you know, the usage of provider impression codes followed the increase in COVID-related incident. It's important to note that even though that happened, the use of these codes isn't inclusive of all pre-hospital COVID encounters. So it wasn't happening as much as it should. Am I correct?
Yeah, it was a slow adoption of these codes. And you can see that in the data. You can see that, you know, slowly states and agencies started adding those codes, but even towards the end of 2020, you still don't have consistency.
Yeah, and I'm going to tell you more data is better than less data. And I'm going to tell you that when we're back next year, we'll be talking about, and we're already going to have it at the EMS Today conference, a lot on artificial intelligence. Artificial intelligence is going to be telling you on your screen, this is probably a STEMI. This is probably a septic shock patient. And if you're in Copenhagen right now and you call in, their artificial intelligence is working in the background and listening, and they can hear, the computer can hear sounds that it's impregnated with of agonal breathing. And up on the screen says, that's agonal breathing. This is a cardiac arrest. So artificial AI, artificial intelligence is going to be all around us. Your patients presented with a wide variety of complaints and symptoms. There were no rapid field level tests obviously available. I think that they will. I think by next year in an ambulance, you'll know within seconds whether this patient has one of the COVIDs. It was a key usage of provider impressions and vital signs, all played an important role of the identification of suspected COVID patients. I had a paramedic crew, I won't say from where, tell me, hey, the first code that we were on, we called the code and we took the tube out, and the tube looked like it had been dipped in maple syrup. Well, you're going to see an actual image that I put in here of a lung from a COVID patient. And it was little things like that that started to spread, like, oh my God, we have to stop intubation. And if we still intubate or get down and even do any kind of a ventilation that involves our own airway, that's bad. That's a breeding ground for trouble. The usage of provider impressions related to influenza decreased by almost 1/3 during the last quarter of 20 compared to 19. Why do you think that is, Doug?
I think that people started looking at COVID-related impressions, started looking at other things, and patients were getting more complex. You know, someone would just call, you know, I got the cold, I got the flu. People were just using that as a default. Now that those populations weren't calling 911 and the more acute, sicker patients were, I think that that's a major reason why those codes started decreasing.
And I think what we're going to show you is that Doug and certainly Morgan and others are looking at all of these things. They're going to be telling us things that are important for us to realize. You'll see my statistic on vaping. You'll see some other things that are going to put some red flags up in the future. If you have a healthy 28-year-old and you say to him, have you been exposed? Have you had the COVID? And he says, yes, I have. Oh, well, okay, we're going to check you out here. Well, that may be the reason that he's calling you for chest pain. He may be in a health club, as I've heard incidents of, where all of a sudden somebody collapses, or other people that are dropping over from PEs. Because again, Pac-Man's floating around in there. The germ isn't necessarily gone once you have COVID. There's some dormancy that lays around in there. So don't overlook anything, because I would want you in a nursing home to be able to identify the person with influenza versus COVID and not be afraid to transport somebody or resuscitate them if they have influenza. We don't capture all the COVID-19 incidents. Other impressions can be used. Now, this gets a little technical, and I'm going to rely on you, Doug, to help me through it all, because the addition of the ILI, the influenza-like illness, and COVID, CLI-like illness, going to caption more suspected incidents in the pre-hospital setting. So how was this established?
So the CDC has the ILI, or influenza-like illness, and then they also released the CLI. Now, you talked about temperature documentation earlier. They rely on temperature documentation on all of their equations. So we had to use other things. We had to look at fever. We had to look at primary impressions. And I think we'll show here in a second is our modified scale that we made that kind of got us the best and closest match to that CDC.
So some of the inclusion criteria included bronchitis, common cold, COVID, SARS, influenza, pneumonia, or at least 2 associated impressions involving fever, respiratory symptoms, or other cold symptoms, correct?
That's correct, AJ.
So the comparative data is based on emergency department visits captured by the NSSP, National Syndromic Surveillance Program. Now, they define fever of at least 100, great, with a cough or shortness of breath or difficulty or presence of coronavirus diagnosis codes. I go blue in the face talking to people about sepsis. I had sepsis the past year. I had sepsis from an infection that I developed after knee replacement surgery, and it ravaged my body. And you know, all of a sudden, when you get that fever, and you get tachycardia, and you get tachypnea, those are 3 things that tell me I'm septic. I got a call from my cardiologist from the little monitor that I have here that just sends out irregularities and said, "Where are you?" I said, "I'm at home." Get to the hospital, you're tacking at 300. God, as a paramedic, I can't tack at 300. I can't have 300 beats a minute. Yeah, you can, because you know what? A normal pulse check or a monitor isn't necessarily going to pick up something that fast. I go to the hospital and they said, "You know why you're at 300? Because sepsis has told your heart that we're coming to get you." And so they had to correct the heart first, cardioversion. I loved it. Highly recommend propofol. And then they treat it and found the right antibiotic for the sepsis. So, and I give you my personal experience because it really is important. Explain this, Doug. It's a beautiful chart that people should understand. For nothing else, it shows you all of the disorders under respiratory fever and 2 criteria and 2 boxes on the left, right?
Yeah, and I wish Morgan was here, but she just recently had a baby girl, so she's on a maternity leave. But we worked really hard, and it wasn't just ImageTrend. We partnered with a lot of other organizations on this, and it was trying to make EMS incidents fit into the CDC. We really want EMS to be a part of the healthcare environment, but because of the temperature documentation, we just couldn't match apples to apples. So we actually looked at millions of records, I think over 10 million when we first started doing this process, and looking at, okay, how, you know, CDC classifies this patient as a COVID-like illness or influenza. What would that patient look like in the EMS environment? And this is what we found. So, you know, do they have a COVID-related impression, that orange box? Or do they have a respiratory or influenza impression? Or do they have symptoms? So we really looked at multiple ways. I called it kind of the dartboard approach, is how could I capture a COVID or influenza-like patient in the world of electronic medical records in the EMS environment? And so regardless of how you documented this, if you put symptoms in, if you did the primary impression, even if you did vital signs, we were able to pull those patients out. And really,
you know, if I was still working in the field, I might laminate this, which I laminated everything, and I might keep this available, because sometimes when you talk to a patient, they don't want to go to the hospital. I just talked to a friend of mine who says he's had a cough, a persistent cough. Is it productive? No, it's not productive. You have a fever? No, I don't have a fever, but I'm tired as hell. Well, he's got 2 of these things here. Go to the doctor, because it could be something pretty serious. You don't know today, and sometimes you have to justify. If nothing else, remember many of these so that you can discuss them with your patient. Say, listen, we have like 20 different things that we look at, and if you get 2 or more of those, you really ought to go to the hospital. I'm telling you, you really ought to go to the hospital. That's all you can do. Upon evaluation of the ILI criteria used by the CDC, you guys quickly identified that your criteria relied on the collection. Theirs really did on the collection of documentation of temperatures. I've always believed temperature, and so as discussed, EMS was only documenting temperatures on less than 15%. So that brought together industry leaders that resulted in criteria for identification of the ILI and the CLI incidents. So utilizing that in the figure chart, incidents that fit the criteria showed similar trends in pre-hospital setting compared to CDC's emergency department data. And that's footnoted there, footnote number 5. Now, the proportion of incidents were broken down by age groups, which I think is pretty important. And the group most affected by the ILI and CLi criteria were the very young and the elderly. And I think that's pretty significant because, as you'll see later, fever is really common in the very young, but it's more important now. If you get a kid who's 12 or 13 with a fever, people were saying during the first months of COVID, kids can't get COVID. Well, we've seen plenty of children that have died. So just picking up on the fever, I think, is really important. So Doug, the proportion of individuals age 18 and older increased while pediatric ages decreased and did not change in the 5 to 17 year group. Anything significant there?
Yeah, we were, the CDC set the kind of the threshold at 16 we were suspecting to see a higher amount in that 16, 17 range, and we really didn't see that. And we could really kind of recap that pediatric incidents were down anyways significantly. So it was interesting kind of looking at these different age groups, and we broke them out by the CDC ranges, and then we took a one layer down and looked and see if we can see any other trends in the lower age groups. So
and what's important for you out of this work that's been done by ImageTrend is that their trends are probably going to be your trends. I can't say that definitively, but I can say that objectively you can look for that. 68% of ILI and CLi calls come from private residents. That's not surprising, followed by 13% assisted living or nursing. Now you're going to find in many areas, particularly in Florida, where they have an overabundance of assisted living facilities, that number will be higher. Influenza provider impression usage decreased by almost 1/3 during the last quarter of 20 compared to 19 of 20. And yeah, I put it in twice. I'm sorry about that. But the reality is that the impressions don't underestimate influenza. Am I right?
Yeah, and it's important to actually document the best impression that represents that data means something. It's being used.
Now, these are questions that I think we're going to be asking from now on. This is directly from the government, and this is a healthy lung on the left, and that's a COVID lung on the right. So again, think of my maple syrup and understand why these people can't breathe. Understand that if they don't call you, by the time that they do, they're on the floor in cardiac arrest and they're non-resuscitatable because basically they've got maple syrup that's going throughout all of their lungs. So the earlier we can get these people to care, the earlier that we can get some drugs into them, keep them off of respirators or get them early onto a respirator can save a life. And again, to you young EMS providers, I'm gonna tell you something. If you think you can't get COVID, there are EMS responders that are dying on the right with lungs that look just like that. Very sad story out here in Southern California. A guy was a 30-year USAR leader, fire captain. And all of a sudden I'm seeing, prayers for so-and-so because he's got COVID. And I'm thinking, he's a strong, young, reasonably 55-year-old firefighter, works out every day. Boom, a couple days later, he's dead from COVID. This is not a disease that reacts the same way with everybody. It can hit you and leave you and never come back, or it can take the taste away in your mouth. It can take away your sense of smell forever. Right now, there are still people who have no sense of smell. Imagine a mother with no sense of smell, and there's a small fire in her house while the husband's working. She can't even smell that there's a fire to evacuate her children, let alone herself getting carbon monoxide poisoning. We're going to find these things. We're going to be asking, have you had COVID? Long haulers, as I talked about before, are going to show up as MIs later on, strokes, PEs, pneumonia, ARDS, gastrointestinal disorders, kidney disorders. And these are people, there's reports of people who never had a problem with their kidneys that now have kidney failure. Brain fog, my wife thinks I've had that every day of our marriage, but it's actually a disguise. But brain fog is something that don't mean to make light of it. is coming on to these people that all of a sudden have no memory of certain things. And we talked about the loss of smell and certainly mental health. There's a lot of people that once they get COVID, they're never the same again. Do you vape? Why would that be important? I mean, why should we be having campaigns to stop the vaping? Because here's what the scientists tell us. The CDC is finding that the vitamin E acetate mixed with THC and other items and flavors can become deadly when inhaled. And here's the important takeaway. People who vape are 5 times more likely to die, not just get COVID, but they've already damaged their lungs. COVID loves them. COVID goes in there 5 times more than the person who doesn't vape. So when you're doing an assessment, say, are you a smoker? No. Do you vape at all? That could be a 16-year-old. You're going to call for a 16-year-old who's having trouble breathing. Say, you really need to tell me because there's a certain way you got to be treated if you've been a vapor. And if that person says they vape, you know, you got to rely on this statistic, because I'm going to tell you who doesn't know that statistic is some of the ERs. Yeah, you can go back. You could take this to the bank and the CDC that's a good statistic. Now, Doug, we're going to talk about traffic-related incidents. I personally have loved being in San Diego Freeway since COVID, because the thousands of people that have been on the highway are either not, they're not commuting, or they're staying in. And even though NHTSA reports that there were over 36,000 motor vehicle crash fatalities annually in 2018 and 19, there were over 603,000 EMS incidents involving motor vehicle accidents in the data set. And this accounted for 5% of all 911 incidents and 27% of all injury-related 911 incidents. Now, you could talk a little bit better than I about the noted decline during the first few months of COVID, and probably that didn't surprise you.
Yeah, we, you know, the stay-at-home order and people traveling and not going to work and not having to go places, we weren't completely shocked that the vehicle accident or traffic-related incidents were down. But and you'll see here in a few minutes, talking about the injuries were kind of part that was more shocking to us.
Yeah, well, they were down 30% incidents for 2020 associated with associated patient acuity levels, meaning criticality, showed an increase in emergent by 10% and critical by 18%. And the NHTSA found that the first 9 months of 20 had an increase of 4.6 crash fatalities. And then the Department of Transportation suggests that there was an increase in riskier driving, to include speeding, driver impairment, not usually utilizing seatbelts, which may be contributing factors. Now, although it's not overall definitive, I can tell you, at least in my county here in San Diego, people are driving like crazy again because there's nobody on the roads and there's nobody in their way. And they're happy to get out and they're just not even paying attention to what's going on. Anything else that you found from the data that you want to talk about here, Doug?
Yeah, we now there's not an official extrication data element or, you know, in the EPCR. There's ability to document in a variety of other spots, but the acuity, and we saw some increases on scene times as well. You know, if you look at, you know, emergent to criticals, that's a 28% increase in injury severity. That's a significant rate. We found, you know, looking at certain particular states, you know, speeding tickets were 15 to 40% higher in the amount of speed people are driving. Less people on the road, people are more opportunity to go forward faster. It just, so it's, I think the biggest takeaway was, yes, there was less traffic related incidents, but people were getting more injured and the death rate was higher.
And in the world that I would love to live in is the world where the hospitals would give us better data back to tell us that the person we brought in from a traffic fatality was COVID positive, and that we probably would find out that some of these people are trying to drive themselves to the hospital when they're really acutely ill and they crash. And then all of a sudden we go back and we look at a fire report and we document that 50% of the people on that scene were not in proper PPE. You see where this whole thing is meshing together? You know, the use of a safety officer at an extrication scene, to me, is pivotal today. Take a look here, and Doug, you may want to address it. I put in some green for the lower acuity You can see what happened to that from 2018 to 2019. And again, lower acuity, there's not as many people driving. But as we said, with driving faster, you could see what's happening in the criticality and the emergence.
Yeah, so if you look at this before, right now during 2020, 1 out of every 10 patients in a vehicle accident were critical compared to previous years. That's a significant increase. We went from almost 3/4 of stable patients to around half. It was a big significant change, and I think people may have not caught that at first because the frequency was less, but looking at the data retrospectively, it definitely added impact to the healthcare system. Longer time on scenes, longer commitments, and more tasks.
Important to think about. Society's changing, and their driving habits are changing again. And the people that are driving fast today are going to try and drive fast tomorrow when there's more cars on the road. So would be interesting to see what happens to that. We're the highest among 16 to 24-year-olds. That doesn't really shock me. And accounted for 13% of all 911 incidents of that age group. Is that going to change anything for your service? It's a good piece of data to keep available when people ask you questions to show where your call volume is. Now we're going to go into alcohol. Drug use was documented in 9.4% of traffic-related incidents in 2020 compared to 8% in 2019. Again, is it because we're coming out of the fog, Doug? I don't think we can predict that yet, can we?
Not yet. It's too early, but it was a significant change. So
you reported it. Oh boy, mental health, a major concern due to COVID. We're going to be talking about behavioral health here now, and this is, the statistics, I think, on the EMS side of EMS providers is something that's really scaring me. And the number of people that have committed suicide, et cetera, is scaring me. But right here now, we're talking about your EPCR data. And it's not only limited social interactions, it's also limited the opportunity for access to mental health services face-to-face. So virtual or remote services replace face-to-face. I can tell you, again, from personal experience, we saw some systems like Scripps Health here who had maybe 600 virtual visits that are up to 250,000 now in a year. Can you imagine that? I mean, I've had all virtual visits with my doctor and I love it. I love it. And you as providers are going to do more and more of that, and you're going to do more treat and release because of that. But again, we're finding out that the mental health aspects have been lagging behind as they have forever. And again, if any good comes out of the bad, it's that people are going to realize again that once you have COVID, or the fear of COVID has caused a lot of problems. Look at this poll here by the American Psychological Association. Almost 80% of adult respondents found the pandemic to be a significant stress in their life, and over 60% of adults indicated they could have used more emotional support over the last 12 months. I'm gonna tell you something, as a responder, I can tell you that when I got my first shot, my first vaccine on January 1 of this year, I emotionally could feel it. When I drove away from that site, I could care less if they took a chunk of my arm off. I was just so happy that I was 50% of the way being able to not fear this disease because I'm overweight. I'm upper in age now. I've had some, medical issues with atrial fib. I've got comorbidity factors. And you know what? I'm not stupid. I've seen people on a vent and I didn't want to go on a vent. So you know where the psychological access is. And as EMS responders, we know that more. So the stress on us is even more. There's been a slight increase in behavioral health incidents in the pre-hospital setting, up only 4%, with the largest increase in October of 20 compared to the previous year. Almost 1/3 of all behavior. Well, let me back up to that. Anything you want to say about that? Is it because people aren't calling us?
Yeah, it's, I think that as the EMS industry, we're doing a better job documenting and capturing these patients. I think we still need to do a better job and still capture those patients and show that, why did they call 911, what's going on. But, on the previous slide talked about, 80% of Americans said they found some stress of COVID, working from home, the change, the fear. And so we weren't really shocked at the increase. But the ramp up speed, we were predicting to be a little bit higher, as certain as, these people that normally see the face-to-face doctor's appointments, counties and states took a little bit a longer time to ramp up those services. They had to order technology. Did the people have access to it? So, 4% was better than we originally thought, I should say.
Well, what I'm going to say as a former ops director is that it is important for you to document for a lot of different reasons. Like, I would beg my crews, don't forget to document why you did a treat and release, because we're going to have to look at that data and find, like, we always knew that our treat and releases increased over the holidays. Grandma was lonely because her grandson or her family couldn't come visit her. And so she'd call for any little problem. I had people that would come back and say, she just said she wanted somebody to be there to care. Well, guess what? These are people that haven't even seen their grandchildren in maybe a year. And so behavioral incidents are very important to document. Almost 1/3 of all behavioral health incidents were for self-harm or suicide related. That's a pretty scary number, but that didn't change significantly over the past 3 years. I don't know if you've talked about any reasons for that, but stress can change, but suicide's a whole different category. There really is kind of a wall between the two. And so I'm not surprised by that, but it's a very interesting statistic.
And we left that in the report just because that number is scary. 1/3 of the patients. And so it wasn't a change, but we thought, people should be aware of this.
And, people are stressed. They're not going out. In the past, there are people that would go out and act up at a bar. They'd have 1 or 2 drinks mixed with their mental incapacity to handle life, and they'd act out, and somebody would call for an ambulance because a fight broke out or whatever it happened to be. And with our social distancing, that may be another reason that that's happening. The pediatric age group, less than 17, saw the largest increase in behavioral health incidents for 2020. I know I'm not shocked as somebody who follows everything that he can on COVID, and the lack of kids being in school and the lack of them being able to be with their friends and the pediatric suicides. I would have even thought, and I'm going to say that maybe in the future we're going to find that number is going to be higher, that the behavioral health incidence is really concerning for me. Any comments from where you guys were sitting on this?
Yeah, we were shocked by that number, but as we kind of looked at it, you think about the isolation, not going to school, the big acute change, the social dynamics of the fear of of this pandemic, and social family dynamics too. It just definitely it's just an increase, and people should be aware that this is a potential, and this is the other part of our care is that mental health care that we need to provide as well.
And compare it to the holidays of 2019 to 2020. And if I was concerned about a 13% increase, how about if I triple that and bring it up to a 34% increase just for comparative months of December to December? That's a pretty bad spike as far as I'm concerned. That's a bad comparative number. And what backs you up is that the notes from the CDC were basically the same for ED visits. And that surprises me, only because the EDs are saying that mom isn't bringing those kids to the emergency department like they used to. So I'm thinking for the emergency departments, there's a lot of patients that just aren't going there, that aren't ending up in that data field. Don't be surprised. Wow, chemical restraints. If I had a nickel for every meeting that I've had where people were talking about justifying why we're using ketamine and EMS crews are killing people with ketamine, we got to stop the usage of it. It's really been discussed all over the place, just because there have been a couple of cases where a police officer said, is there anything you can give them? And then the patient dies, and it's found that the crew gave the patient ketamine, and a couple of bad administrations really make us all look bad. But as Doug will tell you, midazolam outnumbered the administration of ketamine by double, right?
Mm-hmm. Yep.
That's incredible. And ketamine use for any use occurred in approximately just 0.3% of all incidents in 2020 compared to 0.2 in 2019. Now, I'll tell you why that's important is you got to get that number to your medical director, because when somebody wants to take ketamine off your rig, that's the reason that I think you should be able to keep the ketamine on your rig. You know, that it's pretty much standard. We know what we're doing with it. We have a solid protocol, and comparing it to interfacility transports, ketamine had been administered in 1.27 or 1.7 and 1.5. So there's a comparison for interfacility. And organizations such as NAEMSP and ACEP and others have come out and said, been defending the use of ketamine. So make sure you have a protocol, make sure you document it, and make sure that you can use this kind of data from millions and millions of cases to say, we're not abusing ketamine. Now, the usage of physical and chemical restraints for patients nearly doubled from 2018 to 2020. And Doug, I told you I was shocked with that number, right? That's a scary number. And what to me it's indicative of is that there's a lot more patients acting out. There's a lot more patients that are, you know, just maybe 2 weeks ago, maybe even a week ago, it was the EMT in New York got bit in the face by a patient. Jim Page used to always say that he'd tell everybody as an attorney, as a fire chief, and as EMS educator, trust everyone and trust no one, because you just don't know what's going to happen today. You always have to be careful of exactly what's going on. I see the whole social thing changing. So again, do we have all of the data, Doug? I mean, do we have all the reasons? No, but we certainly have the data to show that the use of physical and chemical restraints nearly doubled. And since we showed that things like chemical restraint did not really increase, then that means that physical restraint probably had to increase. And you got to be careful. I mean, you're going to find all kinds of things from these trials that are coming out about spit masks and transporting patients on their belly. You transport AJ on his belly and he's overweight, you're going to kill me, because as I exhale, I'm not going to be able to inhale as much and I'll suffocate on the way to the hospital. So pay very close attention. That last slide, I think, is indicative of why you need some CE and continuing ed on restraints, who you restrain and how you restrain them. It's not your mother's scoop stretcher anymore over the back of a patient as it used to be shown in textbooks. We're not doing that anymore. Evidence suggests there was a significant increase in alcohol use to cope with the effects of the pandemic. I'll admit, I've had 2 glasses of wine, 3 glasses of wine. You know, I've had nights where I just can't even handle the news anymore. I've had people tell me they don't watch the news at all because all they're talking about is COVID. While studies have found an increase in alcohol sales, pre-hospital data shows a decrease in alcohol-related incidents. Again, you and I talked, Doug, you're not surprised by that.
No, bars were shut down, establishments, restaurants, and most people at their home when they're drinking, no one's calling 911 for them. So we weren't shocked by this.
So we're telling you it accounted for 7% of all 911 incidents. There was a slight increase maybe in May when we started to open up the country again. But here's the caveat. Wait, it's coming. When people get back out on the bars, you've seen what's happened on college campuses. You see what's happening now with spring break. People are going to go absolutely wild. You know, the president promises you're going to have a party on July 4th. Guess what's going to happen on July 4th? There's going to be mega parties now on July 4th. Everybody's looking for an excuse to go out to drink again. Not just that they like to overdrink. They're just going to have a good time doing it, and they're going to have traffic accidents, etc. And the inability to interact with others in social settings remained restricted due to bar closures, etc. All of those things have affected it. Watch out as the country opens up. People return to the bars. Pretty significant. Let's talk about drug use now. That accounted for 4% of all the 911 incidents. They saw a drastic increase, 37% during the first few months, but it remained higher than previous years. Anything you want to say about that? Because I have a couple comments.
Yeah, when we saw the spikes, and this is just correlation of data, not speculating or anything like this, but the spikes were, the biggest spike was right after that first stimulus check. So we saw the largest kind of spike right after that, and it's remained high for the rest of the year. We don't know if this is a coping mechanism for people staying at home, but this is kind of what we're seeing across the nation.
Yeah, and I think you're going to see a lot of other data. I don't want to get political on the whole thing, but the stimulus checks open up the opportunity for some people who have a habit, do some things that they haven't done before. Being from a border state, I can tell you that some of my friends in the fire service are getting tremendous calls to the border for incidents, and that there's a tremendous amount of drugs that are flowing into our country right now. So there's a lot of things that are going to change. I think we had 120 children that were, or people that came across the border in the past week or so that were COVID positive, and they somehow slipped through the system and are in your community or mine, and they're going to be super spreaders. So we're going to see, and not just that, but there was a decrease in access to drug use support programs and all defensive people who've had that habit. Narcan usage in the pre-hospital setting is also a really good indicator for you, right?
Yes.
Although it was only 1% of all 911 incidents, there was a similar spike, like a 37% increase in narcotic usage, previously discussed. So, there's people that are looking at some of these studies. My good friend, Dr. Joe Arnato in Richmond, Virginia, he's so concerned that guess what he's done? He's trained 7 drone pilots. And every time they get a call for a man down or a person down, they're going to be dispatching in the next couple of months a drone with Narcan on its belly, and it's going to land and allow the citizens to beat the first responders in delivering Narcan to the citizens of Richmond, Virginia. Tell me that's not going to be an interesting place to study, Doug, because he's identified that that's a significant problem, and he thinks he can get more people delivering Narcan than even those that are going for AEDs. Very interesting to watch. The report, this report by Glenn et al. Found that transport refusal rates in 2020 after Narcan administration were double what they were in 2019. Again, can we suppose what that is? Again, if I wake up, the last place I want to go is to the hospital. And so I believe, that's my theory, that's not based on anything in fact, but just seeing that was double, there's got to be a fair number of those people that simply did not want to be transported to the hospital. Talk to us about peds here, Doug. One of the most interesting sections.
Yeah, it's like we kind of referenced, pediatric incidents were down, but pediatrics do account for about 6% of our total call volume. And, that's kind of what we're finding that's pretty consistent. What we did ask before we published these numbers, we asked agencies across the country, so how much of your pediatric population? We were being told, 14 to 30%. So it's kind of interesting to see what is really kind of what the data shows and what people's perception is.
And you're going to see probably one of the best ImageTrend charts here in a couple minutes as we conclude. But it really brought home one of the things I like about what you guys do, particularly when Morgan talks about some of the trending, that I can see that visually. Patient treated and transport to an ED accounted for 5%. 79% of all pediatric 911 incidents resulted in transports. Again, why is that high? Most people, if they call you to take care of their child, they want the child taken to the hospital. If they didn't, they wouldn't be calling for 911. They'd be taking them in their own car. And so I think that some of it is just based on our whole society in the past. But here's the key thing. In 2020, the top provider impressions included injury, epilepsy, nothing surprises me, mental disorder, the increase I think we've talked about, that's concerning, acute pain and fever. Those were the top impressions, and you could take that to the bank that that's a valid end number and statistic coming to you from this ImageTrend report. Pediatric primary impressions for transported incidents varied across age groups. This is what I found really important. Fever and epilepsy most common in younger age groups. Again, for educators, continue to educate that, because that's still what we're going to see. You can't assume that because that kid has a fever that it's because of COVID. It could be because the kid is teething or other things that children are normal at getting at the age of 1, 6 months. Injuries and mental disorders more common in the older age groups. Again, not overly shocking. Here's what I loved, and I sat, Doug, and I I asked your permission to reduplicate this. And then I put my little colored boxes around here because what this was telling me, and that I could take to the bank from 17 million or whatever number of cases, even if it was 1,000, I'd feel very comfortable with this. From under 1 year old to 1 to 4 years old, that's like 33%. It was fever, epilepsy, acute respiratory distress syndrome, all those things that we've talked about. Maybe some injuries, child falls off the crib, etc., but nothing that would jump out at you that you'd have to say, well, validate that. And then we start getting up in, 1 to 4 years and 5 to 9 years, and we get unspecified injuries of the head. And I can tell you that I have a couple of impressions. Maybe you have your own, Doug, but again, kids riding bikes without helmets on. Are you documenting that? Is that one of your fields? Do you have bike safety programs? Do you have bike helmet programs? Again, that might be innocuous, but it could also be signs of child abuse. It could also be the parents that are tired of being stuck at home, not working, laid off, and the brunt of their frustration comes out on the children. So that's telling me that 7.5% of the primary impressions for the pediatric treat and transport was an unspecified injury of the head. A little bit concerning. Nothing more I have to add on it unless you do, Doug.
Nope, it's just getting that documentation, especially, what was the cause? Did they fall down the stairs? Were they riding the bike? That's the stuff that we really need to kind of validate this data.
Yeah, and then if you look at the upper right, obviously as children get older, there's more injuries that are unspecified, whatever it happens to be, hitting that face with a snowball, whatever it would be. 8.6%, you can take it to the bank of your pediatric calls are going to be for those kind of things. 6.6% are going to be epilepsy, etc. But pop back over and go down and look what's happening in the 10 to 14 year age group. When you get down to it, the third impression is 8.4% here, mental disorder not specified. And then it hops up here as a higher impression for the 15 to 17 year old age group. Now, I'm hoping you guys can break that out a little bit more from the COVID to the non-COVID, because I think we're going to see that that's an increase once we shut down schools, once kids couldn't see their friends anymore, that those mental disorders began to increase. But even purely 3 years worth of data tells me that this is a problem in America. This is a problem in your EMS system. It's not your problem, but it's a problem you're going to see, and you better be ready for it. And where do we take those kids? And how do we convince the ER that they need to see this particular person? I found this to be a fascinating chart, and I really want to thank the gang at ImageTrend because I'm a kind of a visual guy. And now we're going to close up with Doug giving you some summaries of our impressions here. Again, nice and colorful. I'm sorry it's not prettier the way I photographed it, but it's much prettier when you download the report. But I'm going to go down from the top. We're going to talk about the blue area first, and then we're going to close out here. Go ahead, Doug.
Yeah, just the overall call volume in 2020 was down for the first couple months. Pretty known that. And then pediatric incidents were down 19% over a year. So that's a big decrease in that patient population.
But nothing that surprised us.
No, I wasn't. Pediatrics was a little bit down, but with schools closing and kind of that whole COVID out there feeling, we weren't too shocked. This one, the PPE use, I'm going to jump there because 800% increase, but only less than 50% are still documenting. These are optional fields in NEMSIS, the National EMS Information System, maybe mandatory in your state or local area, but we encourage you to use that. You need to justify that usage. You need to show what you're using on those cases. And the temperature documentation, please get temperatures. It is a vital sign, it is essential. And it did double, but 35% is not where we should be. We need to be at 90 or above.
Yeah, and I'm going to give you 2 thumbs up, 2 gold stars, because that's a significant improvement. Sometimes a light bulb has to go on. If you don't have a temperature device in each of your response kits, you better do it. kind of like tourniquets years ago. Nobody had any. Then when they did have them, they didn't have enough. And in Reno, where they had an air show incident, they had 15 amputations in about 20 seconds and 5 tourniquets on the scene. Well, now RIMSA carries probably 24 per vehicle. And I think that we learn over time. Temperature is really important. Traffic related.
Yeah, so even though traffic related incidents were down last year, but the acuity was higher. So just because you're being dispatched for a traffic accident and you're that familiarity where you are used to maybe those like, oh, non-injury, we are seeing more injuries. So keep that in mind. So less people on the road, more severe injuries, faster speeds, more acute patients.
Yeah, and you're going to particularly, I think if we ran the report after midnight, we'd see what that number is. And there's a lot more people, and we're going to see a lot more once the bars begin to open after midnight. And one takeaway I'm going to give you, it's a little stat, not even a stat, but a documentation that you can find. My son's a California Highway Patrol motor officer and always lectures to me, tell your EMS people to stay out of the far left lane, stay out of the high speed lane. I said, why? He said, because drunks don't know which way to get on the freeway. And when they get on, they want to evade us. So they go slow and they're driving in the high speed lane head on into an ambulance that's coming back in a hurry to go back to station. Don't drive in that far left lane after midnight. I think it's important to pass along. Maybe I'll save a life here or there. Behavioral health. I hope we talked about enough of this, huh?
Yeah, it's that stat. A third of behavioral health incidents in EMS are suicide or self-harm. So it's important to recognize those, and that's general information that is just, it's good to know. The crew should be educated on how to handle these patients. And then the pediatric behavioral health emergencies being up 34%. It's another population. We need to look after those younger populations. We need to make sure we're providing the right resources and take them to the right definitive care.
And you know what? We're respected members of the community. So you should be thinking about when schools begin to open up, your service should offer to send a paramedic or an EMT or a supervisor to the schools to welcome these kids back, tell them, we know that it's been a difficult time. We're not counselors, but we can certainly be encouragers, and they look to us and they kind of trust us because we're the good guys. Alcohol, suspected drug use.
Yeah, and not only did we see the suspected drug use increase by 37%, but the Narcan use was right in line with that number too. So it's still a pandemic in itself, or epidemic. We need to keep that in mind that, yes, we have COVID, but we do also have, other conditions going on in the EMS and inside the United States that we need to be aware of, and drug use is one of them.
And again, it doesn't surprise us that pediatric calls and incidents decreased. The kids have been locked up. So one number goes down, the other number goes up. Their ability to learn, we're going to find people with deficits, and we didn't even talk about children with special needs. They're still not having good solutions for children with special needs. They've not only been cooped up, but they can't look at a computer all day. Their attention span is totally different. So we're going to see a different world going forward, folks. On behalf of ImageTrend and JEMS, I really want to thank you for spending the time with us here. Again, we think it's very important stuff. You can download the report at www.imagetrend.com/collaborate report. I urge you to do that. Everything that you heard here today is in that report, is documented, and you'll see in the next slide that you have both my email address and you have Doug's. So don't be afraid to reach out to us. Anything we can ever do for you, we will. I will tell you that, again, 52,000 thumbs up to ImageTrend and all of the ImageTrend customers, the thousands of services who've allowed their data to be shown in here. This is a real tribute. It's not just we're paying amount of money for our data, but our data is being used nationwide and probably internationally, because this is solid data that anybody can look at. So again, thank you very much. Doug, thank you. And we'll have you on the show again. Because anytime you have interesting stats, we want to hear them.
Awesome.
I want to test out some of my theories. Thank you all very much.